switching, and I had hoped to be able to sort my technology so I could see my papers on a different screen, but it has failed me, so I'm going to be switching around between the screen and the papers. So I might call on you to remind us of the agenda at different points. Okay.
Yeah, no problem.
Okay. Are most folk that we were expecting online now, Stephen, or are there still quite a lot of people?
I think that's most people, I think. There may be one or two more. Not sure if Jerry or Simon are here yet.
Jerry sent his apologies.
Oh, yes, of course, yeah.
Okay, well, I think we'll get started then. So welcome everybody to this meeting of Highland Health and Social Care Committee. Can I remind you that the meeting is open to the public, it's being broadcast and will be recorded and available to view for up to 12 months. Can I remind you, as it's a public meeting, can we please just use the hand function to indicate we want to ask a question, or if I'm not seeing your hand up, alert me through the chat that you want to ask a question, but can we please not use the chat facility for any other purposes during the meeting? So could I have the apologies, Stephen?
Apologies from Jerry O'Brien and Tim Allison.
Thank you. Do we have any declarations of interest? Not seeing any hands. Okay, so members, I've had to rearrange the agenda a fair bit today, I'm afraid. So we will be moving around the advertised agenda a fair bit to accommodate some operational pressures on people's time. I will be factoring in a break probably around the 2:15 mark. We'll see how we get on. So can I introduce Elizabeth Smart, who is standing in for Tim Allison today, and so we're beginning with our COVID update.
Thank you very much, and thanks for the invite. And yes, Tim's on a very well-deserved break. I asked for some assistance with uploading the PowerPoint. We can put that up. Thank you. That's great. Okay, and what I'll say is, next slide, please, when I need to move on. So I was just asked to give you a brief update. I wanted to show you the graphs really because of the story that it tells, particularly at the moment, because it feels we're in a very difficult situation just at the moment. The slides.
Elizabeth, can we just have a test to see of the first slide of your graphs, so that we can make sure that people can see that, you know, it's large enough for people to see on the screen.
Yeah, is that
still on slideshow, Stephen?
Right, okay. Right.
There's
a wee icon in the bottom tray, which is the fourth wee icon along.
This one.
This one.
Down at the bottom right-hand corner, Stephen. Next to the, yes, fourth one along there. Fourth one.
Fourth one. Sorry about this.
That's okay.
Sure. Is that showing?
Try again to press on the fourth.
It looks like a little projector, the icon.
Yeah, that one. Try that.
Yeah, I know. The issue, Stephen, is you haven't selected the right part in Teams to present.
Oh, right. Okay. Okay.
So, you know, this morning, Stephen, you unshared and then you opened it as a presentation and shared the presentation as it's already up and loaded.
Yeah, sure.
Okay, let's try that. It's all right. No worries.
It's technology, it's a great thing.
Yes.
Stephen, just oh, it's okay. I'll wait till you've managed. No, it's still not.
Try the icon that says from beginning.
Yes, yeah, it's kind of cutting out. Sorry.
I think you might have to close it down and open it up again.
Yes.
Stephen.
Sorry about this.
Okay, we may just have to.
Is this visible?
Well,
That's very strange, actually, because the little icon should just work. Which
okay,
Yeah.
so let's try that. Let's try that. Try the next slide, Stephen. Okay, so I think we're just going to have to run with this, Elizabeth, and I mean, I can just about make things out, and perhaps I'm sure you'll be explaining and telling us what all this means anyway. So let's just kick on.
Okay, we'll do it. Well, we'll just go ahead and do my best. So I was just saying that Tim's on annual leave, which is why I said I'd cover this. And I wanted to show you a presentation because of the changes in the last week or so around COVID, which I'm sure you're aware of, but it's easy, I think, sometimes to understand when you see the graph. So the information's been provided, you'll know everybody, it's Chris Morgan and from our health intelligence team. So those are my sources of information. So this first slide that I'm showing you is, just change it for myself. So this first slide shows the number of new positive cases of COVID, and you can see that by month. So on the one side of the picture, you've got a number of confirmed cases, and the other you've got cumulative numbers of confirmed cases. And obviously this is going up. And the very worrying part of this is in June, you can see how quickly, how steeply that curve is going up, particularly the 7-day rolling average. Within the health protection team, what's happened is we've had to call in staff who've been previously trained. We've got more staff doing contact tracing. And I just had a quick look at the amount of cases that had come in today. So this is at midday today, and it was 77. And we're getting over 100 a day at the moment. So it's, for us, it's actually becoming very difficult to deal with the number of cases that we then have to follow up through contact tracing. So if I just go on to the next slide. Thank you. So this just shows this is new cases over 7 days, and it's by local authority areas. So we've got Highland and Argyll and Bute. And again, it's just really to show that increase at June. And Highland has more number of cases, but as a rate, Argyll and Bute have got more because of the population size there. So just go on to the next slide, please. So this is just the crude numbers, this one. So it's number and rates of new cases of COVID over the 7 days. And you've got the two council areas, Argyll and Bute and Highland. So that first column there, which is 7-day numbers of confirmed cases. So if we look at Highland, that is 354. And then the previous 7-day number of confirmed cases was 63. So again, this shows the amount of cases that are coming through, and it's repeated through all those columns in that particular table. On to the next slide, please. Okay, so this is the PCR test, and this is when the actual specimen was taken. As this is across Highland, and you can see the daily figure, which is the purple. The 7-day moving average is the green line, and then just at the end, actually you can just see it's July. It's light grey. Those we're just waiting to catch up with those cases there. But again, it just shows a picture of the 7-day moving average just creeping up. This also shows that around September 20 and January 21, we've got peaks, and you can see that where we are now at the end of June, that peak is as high as any of the other peaks. So this is why we've suddenly become really busy again. If you just go on to the next slide, please. This is a slightly different picture, though. This is the confirmed deaths, and again, we've just got it split into Argyll and Bute and into Highland. But you can see for April and May, we actually have no deaths, which is very different to what we had earlier in the year. And you can say that this is part of the success of the vaccination programme. And the next slide, please. This is just the heading here of, I just wanted to give you a bit of a vaccination update, actually. So if you go on to the next slide. So we've got two graphs here, and they show the doses. So it's people who've had 2 doses and people who've 1 dose of COVID-19 vaccination. And you can see that across Highland, we're doing really well. So people who've had 2 doses, that's approximately 64%, and people who've had 1 dose, it's around 85%. So as I say, we're going really well with this particular programme. If you just go on to the next slide for me, please. So this is probably of particular interest to this committee because it does show by age banding the vaccination. So the light blue, or it maybe comes over a little bit as purple, is the 2 doses, and the dark blue is 1 dose. So you can see for the cohort which we're working with at the moment, so that's looking at 18 to 29 and 30 to 39 roughly. You can see that for 18 to 29, 17.6 have had 1 dose, but 40.9 have had 2 doses. But right at the other end of the spectrum, which is the good news part, you can see for older people, if you look at 75 to 79, and if you look at 80 plus, you can see that we're almost at 100% vaccination for these two groups. And that is by the cohorts that the JCVI have asked us to work with. So just go on to the next slide, please. So this is a bit of a summary about the COVID vaccination. So you'll probably be aware it's in 3 tranches. So the vaccination of the adult population 18 plus is tranche 1, and that is to be completed by the 18th of July. And you can see we're well on the way to that. Then the tranche 2 is the delivery of flu vaccination and COVID boosters, and that's to begin on the 1st of September. This is no mean undertaking. I know that's stating the obvious, but it really isn't. And then tranche 3, it's to be confirmed, as you can see from that little table. Just a couple of other comments. So fulfilment of 11 and 12 cohorts, that's 18 to 40-year-olds, is in line with plans. And although NHS Highland was a little bit behind in comparison to other boards, we're actually doing all right on that at the moment. But the geography of Highland and the mixed model in that it's vaccination centres and GP practices has meant that Highland has progressed a little bit more slowly through the cohorts recently. The second dose clinics are expected to be completed in mid-September, at which point tranche 1 will be closed. You'll probably be aware that there's, I kind of call it open access, as drop-in centres have or facilities now been open that anybody can just pitch up and get a vaccine done. So as I say, we are moving well through vaccinating the population. And if you just move on to the next slide. Yes, it's just about boards, and some of you on the meeting here will probably be much more involved in this than myself. So plans for that to be submitted to make sure that we complete the tranche 2. And then the final slide is just again to say that this information has come from Chris Morgan and our health intelligence team. So thank you. So that was just a brief overview of the COVID situation and vaccination programme to date. So thank you.
Okay, can we just leave that last slide up for the moment? Thanks, Stephen. Okay, thanks very much, Elizabeth, for that overview of where we're at. So first of all, any questions for Elizabeth or Louise in terms of the impact of the current situation? So I've got Philip, Wendy, then Mike, and oh, we've got quite a few. Okay, so I'm going to take this just in groups. If I could, please. So I'm going to come to Wendy, Mike, and then Philip, and then I'm going to pause so that Elizabeth can answer the questions. So Elizabeth, if you can just be jotting down what people are asking, and then I'll come back to you after those three to get a response. Okay?
Yeah, it's not, well, I'll do my best, and if necessary, I'll go and get you the information. Thank you.
So if you bear in mind that Elizabeth is in the public health team, not the vaccination delivery side of things, and so if you have questions about that she can't answer, we may have to send the information round out of the meeting. Okay, so sounds like that's a plea to treat her gently, but we'll get the answers if she doesn't have them. Okay, so Wendy, then Mike, then Philip.
Hi. Well, my first impression of that report was how interesting it was and how very helpful I found how that was particularly delivered. So thank you for that. I was wondering, thinking ahead, are there any plans for data to be collected for people that have had both COVID jabs and have been reinfected with COVID, whether they have had symptoms or not, they've been retested and that's been identified?
Okay, Mike?
Yes, can you, I think it's a public health one, can you give us any idea what the health intel view is on why we've had this surge, and what is the mean age range?
Okay, and Philip, and then we'll come back to you, Elizabeth.
Yeah, my apologies. It was a vaccination question, so I'll withdrew my hand. But I will say that the slides there are incredibly encouraging, and I think both in terms of who has got the reports in with no hospitalisations, but also with vaccinations. But it might be a question you can answer. It's just in the open access drop in. I just wondered where these centres were, how many they were, and what coverage they had. I understand with you not being involved in the vaccination programme that that's not a question you might be able to answer.
Okay, Elizabeth.
So the first question was about data collection, and it was about when people have 2 jabs and about being reinfected. All I can say on this one is there's a substantial amount of research going on, led by a number of universities, and this is the sort of thing that they are looking at. We do know that people who have certainly been jabbed have ended up with COVID, and obviously some of this is emerging as well as we move through the pandemic. It's possible someone on the line could answer that one better than me. I don't know, but there is a huge amount of research going on in these areas. The second question was about why this surge at the moment and the mean age range. Well, we know who is getting positive test results at the moment, and here, and I have to say the football has a lot to answer for. we've done a lot of contact tracing, and it does go back to football. So we are really seeing the unvaccinated people coming through with COVID at the moment. Teenage, it's sort of 30 years of age, and I do wonder how going forward with more social restrictions being lifted, what this is going to mean. But obviously, the more people we can get vaccinated in the public, the better for this one. And then the third question, there's a portal available on the internet. It will be through NHS Inform that people can go to for booking a COVID vaccine. Where they're actually cited, I don't know, but there is that portal available at the moment. If you want me to, I can go and find out. I know who to ask about where those sites are going to be. So it's probably a mixture of existing sites and being able to schedule people into those existing sites. And I think it might be worth asking if anybody in the audience or the participants here can answer any of those questions better than myself.
Yep, okay, so does anybody want to add anything to what Elizabeth has said there? Can you please just come in, because I've got too many hands to know who wants to say what. Paul, I think you maybe want to come in.
Well, I'll come in. I just posted to chat just from the Travelling Tabby website. It's a really good website that you can look at for data. It just presents graphs in a very easily digestible format. So you can see in the chat the graph that states where we're seeing the majority of our new cases, and it certainly is in the unvaccinated cohort that remains, mainly the working age population. And that certainly is why we're seeing such an impact on our staff availability, because of contact tracing, because of individuals actually having the infections themselves. So we're not seeing the same significant impact that we had in the first two waves with our hospital admissions and with severe illness, but we're seeing a different impact due to the volume of cases. That was all I wanted to say. Thanks, Chair.
Okay, right. So did anybody else want to come in with any additional information, for example, about the open access drop-in clinics, or just shout? If not, I'm going to go back to the questions.
Could I come in?
Yeah, Simon.
My apologies. It's really just a further point. So this is told us something about incidents. I just wanted to reinforce for members of the committee what the impact of some of this is. So as at today, we're back to now having 4 care homes that are closed to admissions because of positive tests. We've got another 4 that are closed to admissions for a range of reasons, including large-scale investigations, but also some of that's tied up with issues about staffing stress and such things. And that's coming on the back of Brexit, the impact of furlough, the NHS recruiting from the same pool as other people, etc. So the key thing for me is really to amplify what Paul was just saying, is that whilst we're not seeing the levels of illness, which is obviously really good, the big concern certainly that I have at the present time is the stress and risk to care and carers, both informal and also formal. But I'm going to particularly focus on the formal care here, because we are seeing that care at home providers are unable to pick up care, and the care homes themselves are seeing increased number of staff unavailable to care. So we're back into that tricky position we were in before. And if we take the illness bit out of the equation, it doesn't change things. If you remember, in the second wave, the worst position we got to was that we ended up with, off the top of my head, if I remember, it was 23 care homes out of 68 were closed to admissions, and that equated to about 125 beds that were lost to the system. But also that equated to masses of staff and masses of people in a really, really quite challenging position. So I think it's great that we're getting good news about aspects of this third wave, but for me, there's some pretty worrying stuff in there as well, just in terms of the sustainability of the system. I just thought it was helpful if I put that in. Hope it was.
Well, it's helpful to a certain extent, Simon, but what I'm interested in is how we're mitigating the risks as a result of that. But I'm going to come back just before we move on from this item, to ask Louise and whoever else wants to come in to tell us a little bit about how we are trying to manage these very difficult pressures we're experiencing right across the system. For example, some of you may have heard the reports on the media today, pleading with the public to direct themselves to the right place at the right time for whatever their query is. So I'll come back to that issue, Simon. I'm going to take a question from Deirdre and then Biz, and we may have to move on at that point and deal with any other questions out with the meeting, but I'll see where we are once I've heard from Deirdre first and then Biz.
Thank you, Chair. And part of my question has actually been answered. The government strategy, as we know, is to ease restrictions as more people become vaccinated. So there's a real tightrope being walked between opening up society and not overwhelming NHS. So we have a majority protected by vaccination. So if we're looking at harm reduction, the people who don't have the option of vaccination are now exposed and at much higher risk. Now, we understand this is effectively the working population and younger people. But my question is, do we have a really good understanding of who these people are who are being exposed to harm? I would suspect it's people who are already exposed to inequalities in life, people with underlying health conditions, etc. So also, is this being looked at nationally, and what are the implications for these people?
Okay. Biz, what's your question? And then I'll come back to Elizabeth to answer.
You can test positive for coronavirus, but not actually have it yourself. That means you're a carrier to other people. Will you ever get just any symptoms yourself? And with the restrictions on the horizon for being lifted in the mid-July, and you mentioned football matches as being an area that were spreading it. Are we lifting the restriction too soon?
Right.
Okay. I think
the questions.
That last question may be above Elizabeth's pay grade. I might ask whether somebody like Paul wants to make a comment on that, but I'll come back to that in a minute. Okay, Elizabeth, do you want to have a go at the rest of that?
I was going to ask if we can just go back to one of the graphs. Actually, it's number 9. I think it's slide 9, and it shows the cohorts. That's right. So this is how the vaccination programme has worked through the various cohorts. And the cohort we're working with at the moment are basically the 18 to the 49-year-old age group. And they're the ones that are being targeted. And that's predominantly the working age population. So that's work ongoing. It would appear that we will reach most of this population. In terms of groups that whether suspected difficulties in engagement, there has been some additional pieces of work done to try and do extra to encourage them to come forward for vaccination, and that's everything from alerting services to particular cohorts right through to social media and media coverage. So that's how I would answer that particular question. But we've got this data nationally. We've also got it locally. I can produce both national and local charts for you, and down to Argyll and Bute and Highland Council area. So this is the sort of thing that is being scrutinised all of the time. There is a lot of work going into this. And in relation to the final question, it really relates to policy decisions and politics, I feel, and we just hope that actually Jason Leach does a good job in terms of advocating for public health. But we just hope that they listen to the data and they listen to public health messages from chief medical officers and the directors of public health group. What my opinion is, it's irrelevant to that broader question, really. What I can tell you, though, is I did a lot of contact tracing for people who'd been at football matches, and spoke to a lot of people who'd ended up getting more than they bargained for when they visited London. Thank you.
Okay, so Elizabeth, I think perhaps one aspect of Deirdre's questions maybe hasn't quite come across. I think Deirdre was asking about people who, for some medical reason, are unable to be vaccinated, rather than either people we're missing or who are choosing not to become vaccinated, and what the implications really are for them going forward in this situation, and you know, if they're, well, just really what the situation is for them in terms of us being able to deliver good services to those people.
Yeah, sorry, I obviously misunderstood that.
That's okay.
Yes, we get quite a lot of calls actually from general practice about this, and in fact there's very few people who can't receive the vaccines, very few people, but for some people they do have a problem receiving the vaccine, and there is a whole process that they go through. The GP usually completes a form, and then that's taken to another meeting, and that's across Highland, where they discuss particular cases. And I'd say it is few people who can receive this particular vaccine, but there will be one or two who can't. What we would hope that over time there's enough people vaccinated, so there's kind of overall public cover, accepting the fact there's one or two people who can't get vaccinated, but it is very, very few people. I hope that has answered the question a little bit better, but there is, I suppose the key thing, there's a process in place to do this properly.
Thank you. Thank you.
Chair, you're muted, unfortunately.
He's still muted.
Sorry. I was just asking whether yourself, Paul, or Louise wanted to address the broader question about the current strategy and what considerations are having to be balanced at the moment, and why the impact, well, the reduction in hospitalisation is perhaps leading to a different view of where we are. But if you don't want to respond, then that's fine as well.
I'll make a couple of comments. I think Liz was very wise to say that there is wider politics and policy at play here, which is above all of our pay grades, really. The Chief Medical Officer yesterday was very clear, however, that the connection between COVID-19 and severe illness requiring hospitalisation, that connection has been very much broken by the vaccination programme, which is wonderful news, and that's the good data that is proving that now. The risk to the population is really secondary to behaviours where they're in close contact, particularly in an indoor setting. So the football's been a big element because that put a lot of people in trains and buses in very close confines. But there are other other presentations within the community. We were seeing family groupings or groupings within community groups and so on. Hotels and schools have been affected as well, and we do have safety measures still in place, and we do ask the public that they continue to adhere to those safety measures, including social distancing, use of masks, the use of proper hygiene, all of the things that we've heard for the last subsequent months. Those are still in place, but the 19th of July, when we take the next step down in our levels, we are hopeful that the balance between significant illness and vaccination will be very apparent, and that step can be taken. But people will still get COVID, and people will still get some degree of illness, and it's not pleasant. It is like an influenza, it's not like a common cold. It's significant illness, and it will still require us to be off work and to be contact traced even at that point. But in general, it's a hopeful picture, and vaccination is the key.
Okay, thank you, Paul. And just to finish off, Louise, would you be able to say something, and well, back to Simon as well, about the kind of measures that we're taking to try and mitigate the extreme pressure that's in the system at the moment from staffing issues due to self-isolation.
Yeah, absolutely. And it is a constant challenge. And I think one of the biggest challenges that I see is the fact that this has been going on for so long that staff are pretty tired, to put it mildly, and there's a lot of exhaustion and fatigue out there. We've also got a challenge in that a lot of people are carrying over leave from last year because of being allowed to carry leave because of COVID. So we're going to have that knock on into this year and beyond. So there's a couple of other factors that can add a bit of depression to this, but equally the teams are really working hard to look at doing things as flexibly as they can. We are relying on the bank and looking at agency to shore up where we can, but also we've got 2, 3, sometimes 4 times a day flow meetings that are across the system where people come together and try and support people to move through to the right place of care. Again, that's a challenge when you hear from, like Simon said, where care homes are closed, although at the moment they're not closed to any degree the level they were previously. So we're hopeful that will continue. So there's lots of work going on in the background. We've obviously got, that you will hear about later, enhanced community services that is trying to support people moving out of hospital more quickly. We're looking at working with the Scottish Government about how we can continue to enhance those things. We had a meeting with them today about that. So there's short-term things that we can do to try and minimise the impact on services, but there is always going to be that pressure, and there's going to be pressure points. A&E, for example, particularly as the tourist service season and school holidays ramp up. So it's about us trying to plug the gaps wherever we can, but acknowledge that there's going to be pressures. So trying to send out that message to the public that you mentioned earlier about use your services as minimally as you can, but acknowledge that people still do need to access the services.
Okay, thanks very much. And I think we'll have to move on at this point. So thank you very much, Elizabeth, for stepping in on behalf of Tim and for that useful presentation. So can I move on then and ask Rhiannon to give her presentation on the Enhanced Community Services report.
Good afternoon, and Stephen again is going to show my presentation.
So just sorry, this is relating to item, well, it's described as 3.3 in the agenda. It should actually be 3.4 because I think we've got 2 3.2s, but it's item 3.3 on the agenda. Thanks very much, Rhiannon.
Apologies, second time lucky. Is any good or still?
Yes, I can see that. Thank you, Stephen.
Right, okay.
Okay, so if you could go on to slide 2. You okay, Stephen?
Oh, sorry, can you not see that? Or...
I can't see slide 2. No, oh well, no, it hasn't moved for me.
Apologies for this. I'll try again.
Brilliant. I've got it now. Thank you very much. Okay, so the paper that's come to you today that's been in your pack, I'm assuming you've all got and have been able to read, because I'm unable to show you them both together. So that what I'm doing here is presenting to you some of the background and some of the bringing out just some of the perhaps more salient points in the paper that I'd like you to know. So the Enhancing Community Services has a background from the effect of the COVID-19 pandemic. So during the COVID pandemic, there was a clinical expertise group set up because we were having to make such very fast-paced decisions, clinical-based decisions in reaction to the effects of the pandemic. And they produced a paper called Enhanced Community Health and Care Model, which was in June 2020. And basically outlined outlines the steps that they felt as the clinical experts in the organisations that we would need to take to manage demand as we go on. So it's essentially about keeping people out of hospital wherever we can, and when they are in hospital, that they're in there for the shortest period of time possible. So it mirrors Scottish Government strategy in terms of integration and and also NHS Highland strategy in terms of better health, better care, better value. So it's about seeing having the people and the people, the staff, to treat them in the right place at the right time. So based on that paper as background, we began with a stakeholder workshop around what we could do as an organisation to try and meet these demands, and that workshop was led by Pam Dudek as our Chief Executive Officer. And following that, taking all the information that we managed to gather from the workshop groups, we established a steering group in September 2020, which is chaired jointly both by myself and Tracy, as we were both heads of service at that time right across North Highland. So the steering group is a North Highland steering group. But as we move through the slides, you'll see that there is a bit of a focus on Inverness, but it's something that we would like to see move across the whole of Highland as we go on. Okay, so if you could move it into the next slide, please, Stephen. Okay, so given the strategic context, which is remobilisation plans, we have our own remobilisation plan which fits in with the government's remobilisation plan, which I know you've all seen here in this forum. Within the remobilisation plan, this sits within as a scheduled care enabler. So within that, we applied to Scottish Government for funding within the remobilisation plan, and were successful for achieving that funding for the Inverness area only. So you can see how the Inverness has had a focus up to this date. It was a considerable amount of money. It was just under £1 million. And that was achieved in September to see us through to the end of the financial year this year. So that was March 2020. Within NHS Highlands strategy now, we also have a one-year strategy recently developed by Pam Dudek and the chair, Boyd Robertson. And within that plan, it sits under integrated plans and unplanned health and social care in terms of a home first approach, which I'll come on to in a little bit more detail in a moment, and also in terms of developing the integrated teams much more so at a local level. Okay, thank you, Stephen. So in terms of how we've gone about implementing, as I said, we have a multi-stakeholder group, which is a North Highland steering group. Within that group, we have people who are involved in the day-to-day changes, so people from the teams led by the area managers. So we have our 4 areas and 4 area managers. We also have a very, very good representation there from across the organisation, including the acute sector, because obviously our impact is on the acute sector as well as within the community, and also across our other divisions, including adult social care, with our GPs, both our in-house and independent GPs, some of our independent sector providers, and all of our professional leads. There's also quite a large work stream with in palliative care, being led jointly with the hospice, which is having an effect where we're joining in with them here too. Tracy, also as joint chair, is also the lead on many of the unscheduled care work streams, which also tie in together. So it isn't a piece of work that's done on its own. The local implementation groups are led by the area managers, and they will include more of the integrated teams and the local providers, including the independent providers, the professional leaders, the GPs, and we are employing QI methodology or quality improvement methodology to give it some sustainability and robustness, and enable us to measure the impact. So in Inverness, we have the large-scale change happening, supported by the funding from Scottish Government, and in the other areas at the moment, we have much smaller defined areas of change, which are outlined in the paper, and that's based on what the teams are identifying they can do themselves at the moment without funding. So our future is going to be working on identifying what we can do longer term based on the Inverness model, from our learning from the Inverness model, applying that into the local areas with their local knowledge, and also how we make that sustainable in terms of injecting some money into there as well. Thank you, Stephen. Into the next one. So just to be clear, what are enhanced community services? What are we actually talking about here? So there are 4 principles here. One is about improved coordination, and that's the multidisciplinary person-centred decision making right at the core of it. So this is about enabling the teams and having the right people in the teams, the right skill mix in the teams, to be able to have the discussions and supported decision making around what is best for the person. And then attached to that is coming down here. On the second point is improving our knowledge of who those people are. So both people in hospital and people who require support. So a very coordinated decision making around people, a very early identification of people, so that we are anticipating what it is those people need and where they need it. And then on to the third point is making sure we have the people available in our teams to be able to respond. So virtually all of that money, apart from some that's gone into equipment to support this, has gone into staff. So we've increased capacity in the community team to be able to respond. And the fourth item there, the fourth bullet point, is around youth pathways. So Home First is a pathway which identifies people who are very, very early into hospital, so right at the admission point. And we are, as a team, ensuring that having identified them early, in a coordinated way, being able to pull those people out of hospital and pull them out into an assessment. So even the assessment in terms of what they need at home happens at home. It doesn't happen in a hospital environment. Another new pathway is in being able to identify people at home, is that we can then anticipate what it is they need and actually avoid an admission altogether. So we're anticipating the crisis and avoiding admission. So those 4 points are essentially what is different, or what is improved. That's what we've been aiming to improve in our enhancing services. Thank you, Stephen. On to the next one. So in terms of evaluation, there have been some very, very positive early results. There are a number of graphs in the paper. I think the main points here are there has been a reduced length of stay both in Raigmore and the RNI. So in the RNI has RNI has moved from 55.8 average day length of stay to 14.8. Which is quite incredible. And you can see that on the graphs related to the RNI, the number of delays is actually a flat line, and that has been since we've put this into place during the COVID period. There've been very, very positive feedback from trials in NEN and Midross from staff. And from patients, and a figure there from Midross is that they have been measuring the wait that's been experienced for people to enablement, whether they be in hospital or the community, and their wait has reduced from 35 days on average to 4 days on average. So we've had a great improved staff experience across the board for people who have been involved in these smaller scale and larger scale changes. Certainly from the RNI experience, one of the things it's enabled us to do is to have a much better idea of the bed capacity that we require in the RNI, and we've been able to use the information that we've gathered to be able to consult on the future of that, which we've been doing with GPs and some of the community in Inverness. Okay, thank you, Stephen. On to the last one. Okay, so I suppose as I've touched on, what we are looking to do for the future is to secure investment for sustaining and furthering both the Inverness developments, but also implementing the principles across North Highland, building on our local knowledge that we've been gathering in some of our smaller scale changes. And another high priority area would be about developing a performance dashboard and being able to have very easily or readily accessible information. What we're doing at the moment is gathering information or reporting on things that we already collect as an organisation, such as you can see here, length of stay and delays. But there's also information required around activity in the community teams. Which is very, very difficult to gather. It's done by hand and it's adding to the workload of the local teams, and it's not easily or readily reportable. So we'll be working with planning and performance on that, which they have, as I say, have given us a considerable amount of support already. Okay, thank you. Open to questions.
Okay, Rhiannon, thank you very much. That was a really good overview and context within which we can input the paper. It sounds very exciting and potentially a great good news story if we can further develop our performance reporting on this, but I'm sure that a number of the committee members will have some questions. So I'm going to go first to Philip and then Michael and then Wendy. And then we'll come back to Rhiannon for responses and then see if there's any further questions. So Philip, do you want to go first?
Yeah, thanks very much, Anne, and thanks, Rhiannon. That was very positive results with particular kind of emphasis on the reduced lengths of stay in the RNI and Rigmore. I just wondered, with that, how do we assess any adverse impact there, where there are perhaps people who should be admitted who aren't, and are there any unintended consequences as a result?
Okay, we'll note that one. Michael, do you want to go next?
Yeah, I was wondering that you secured just under £1 million for Inverness, and your last slide says that you'll be implementing the principles across North Highland. Are you sure that you can secure similar funding for North Highland?
Okay, and Wendy?
Hi, I found that equally very helpful and very positive. Just to go back to the initial, I think it was the first slide when you talked about stakeholders, and I remember reading in the report that it would seem, unless I've missed something, that stakeholders, clinical models have already been established. Now, what I didn't see in any of the stakeholders when an example was being given was carer representation, and I would like to know and have some kind of reassurance, I suppose, that going forward and in the spirit of the recommendations from the Feely report, are they going to be implemented, carer representation as full partners? Okay, right, I'll come back to Rhiannon and just in the meantime, Adam, yes, I'll come back to you in a moment. So Rhiannon, do you want to respond to those points that have been raised?
Yeah, thank you. So adverse impacts and unintended consequences, I suppose they would be identified in the same way that we would identify any harm that's caused now through our reporting system, through our DATIC system. However, we would also, as part of our evaluation, be asking for experience as well. So there may be things which are not quite as dramatic as you've mentioned there, which are unintended consequences and more related to outcome perhaps than harm, which we wouldn't necessarily pick up through our more formal processes such as DATICs. So part of our evaluation would be to ask for what the experience has been like. So we'll be asking patients and in fact carers, which is perhaps coming into one of the other areas, for what their experience has been, and taking that on board and making changes from that. So patient experience or anybody's experience of a service whether they be a patient or a client, and whether it be health or social care, is key to understanding whether we as an integrated organisation are achieving any of our aims related to integration, which are obviously better care, better health and better value. A better care being the experience of care. So part of the evaluation I would pick that up, and anything major which creates harm would be picked up by our current systems. I don't know if that's a helpful answer.
Just go on and answer the other points.
Okay.
And then I'll come back to the questioners. Okay, Rhiannon, thanks.
Can we secure similar funding? I very much doubt it. What we're looking to do is to secure funding based on, there are a number of avenues that we're looking at. We're looking at what we can do both in terms of identifying locally what teams can do, but also, for example, around the releasing of some if we take, for example, the RNI, we're looking to release some funding from that and then reinvest into the community. To be able to do that, we need to identify what it is in the local areas that they can do. We almost certainly are not going to get the same level of funding, and we're going to be, I don't think, getting that from government. So we're going to be looking to do that internally, but it will be through the local teams identifying what it is they think they can do. In terms of stakeholders and carer representation, you're absolutely right. There hasn't been very specifically carer representation. So we have included the Senior Citizens Network and Let's Get On With It in some of our consultations, but there hasn't been specific carer representation. I'm happy to look at that.
Perhaps on that last point, Rhiannon, you could say a little bit about what consultation you are doing on the RNI and the Inverness services going forward, and how the community and patient and carer representatives are involved in that.
Yep. So in terms of looking at the required bed capacity in the RNI, we're taking the information that we've gathered from our work out to members of the community, and that is through the Highland Senior Citizens Network and the Let's Get On With It networks, and also through the GP forums. There's a 12 practice forum and also the GP subcommittee. The area manager and the district manager have taken that out for a consultation through those organisations and have come back with some of their feedback.
Okay, I'll come back with an ask on that at the end, but if I could go to Adam, then Deirdre, and then Fiona Duncan, and then I'll come back to you again, Rhiannon.
Thanks, Anne. Thanks, Rhiannon. Yeah, as my question has probably been largely answered, which was about securing the investment, and I think you've covered most of that, Rhiannon. It's clearly going to be challenging, though, and because we know what the financial situation is, and you've clarified that we won't be expecting additional money from the Scottish Government, I think.
Okay, can I move on then to Deirdre?
Thank you, Anne, and thank you, Rhiannon. Rhiannon, can you advise how this work relates to any future strategy in respect of our community hospital?
Did you hear that, Rhiannon?
Yeah, sorry.
Oh, sorry.
Sorry,
I'm getting mixed up. I'm mixing up my people myself.
I thought there might be another question.
Sorry, Fiona Duncan, you're up.
Thank you. I'm Fiona Duncan. I'm Chief Social Work Officer for Highland Council. You know, that was really, really interesting, and obviously it's the direction of travel and what we want to develop. Yes, we want waiting lists to reduce and time limits to reduce, but I think what's really important for me is the impact that it's having on life outcomes. That's the bit that we really need to know, that people's lives are improving and they are actually getting the service and support that they need, and that will change. So obviously within the system, we need to build in flexibility, and probably that flexibility is part of the process as well. So some people might come in with a need and then come back relatively quickly with something else. So I think that's the part for me, which is, yes, you do want people out of hospitals as quickly as we can, as long as it's appropriate, we have the proper assessments done, we have the appropriate supports in the community. And again, probably when we widen it out to Highland, we then have the question of parity and fairness, and that obviously in terms of geography is what is and will continue to be our biggest challenge. But I suppose it's just what we're aiming to do in terms of measuring outcomes. Thank you.
Okay, Rhiannon, I think it is back to you now.
Okay, so in terms of the community hospital strategy, this is it's absolutely wrapped up together, because the community hospitals are a part of that integrated community team. So the use of the community hospitals is absolutely interlinked, and that's been demonstrated by the information, I think, and the impact on the RNI through the work. But also this team, in terms of avoiding admission to Regmore, also use the community hospital to do that. If an admission is necessary, then can it be done in a community hospital? What do we need in a community hospital to be able to do that? And can we limit that stay to as little as possible? So that's very much within the thinking. So I don't think a community hospital strategy is necessarily different to what we're doing here, and it's going to be dictated by this work. In terms of impact on life outcomes, absolutely, Fiona, I totally agree with you. Some of that, I think, I would hope is going to be picked up in the evaluation. But as the focus on outcomes is there in all of our work. It's not just in social care; it's also there in health. But it is one of those things that we would have difficulty counting. Again, I'd be looking for some help on how to do that.
Okay, perhaps before I come to Louise, who's wanting to come in, Rhiannon, in terms of the additional funding that you're saying will be required, is the expectation that each area will have to look at their budget and whether changes can be made within it or within the use of their staff individually, or will we be taking some sort of overview across the patch and perhaps having to develop a business case for further investment in these services as part of next year's operational planning? Or how do you see that issue being resolved?
This isn't something that can be done through local budgets. So what the districts are doing are using their resources in an alternative way at the moment, in small scale examples of small scale change that have been given in the paper, and then are using that experience to be able to inform a wider business case. So I would pull together something that's on a North Highland basis to look for investment from the organisation.
Okay, so I'll come to Louise next, and then Elaine.
Thanks. It was just to respond on the funding element of it. We are actively pursuing some additional funding with the Scottish Government for this. Literally today we had a conversation with them about it. I can't guarantee anything, but they are pleased with the progress we've made on this, and have actually we've sent them a number of slides and information on where we are so far, so they are quite positive about supporting us if they can. Realistically, to have exactly the same model as Inverness would be very tricky, That's the reality of working in the different settings. However, the teams in, for example, Caithness and elsewhere have already taken on some of those principles, and if we can enhance those teams, we think that we could to make a really good model in the different areas, taking into account the different needs of each locality. So we are actively pursuing that money. However, if we don't get additional Scottish Government money, I am internally looking at what other options we've got for any additional funding. So we are exploring that very actively. I just wanted to let you know that.
Okay, and Elaine?
Hi, thanks. I'm really just building on what Louise has just said there about funding. There's a number of areas where we're doing things differently as a result of COVID and subsequent remobilisation. And whilst we've got significant funding from Scottish Government, it is actually non-recurring. So what we need to look at doing is how the services will be delivered going forward, what the cost of them is, and then build them into the planning processes you mentioned for 2022, 2023 and future years as well. So it's an expectation that we will be discussing where our priorities lie and what areas will be funded as part of the planning round for next financial year.
Okay, are there any opportunities here then in terms of our strategic objective of shifting resources from our hospital sector to the community if we are indeed making significant inroads to flow in the hospitals through this sort of project?
There is a definite possibility, because we are currently running with one ward less than we had in Inverness previously. We haven't made a final decision on that ward not being used again in the future, because we are still looking at engagement with the local community and GPs, etc., etc. But certainly we haven't needed to reopen that ward at the moment. So we are exploring whether there's some funds from changes of use within the board.
Okay, are there any final questions for Rhiannon before I sum up here and we move on to the second part of our paper? Wendy?
Just reflecting back on the report, and it was identified in the report that there are some challenges, even though there's been great steps made with discharge from hospital. There was a comment in the report that said that some social care challenges. I just wondered, in order for people to be discharged from hospital, I was wondering what are they, and how is that being looked at?
So the social care challenges are around capacity. So what the team in Inverness have been, or the model in Inverness to date has been with a model of working with the independent sector providers who have been able to very quickly respond, but do reach a point of capacity, as do all services. So we are looking at both. We're trying to analyse some of that data and look at some of our in-service models to see how we can also support that, and going forward perhaps look to see whether there needs to be more emphasis and into the independent sector or into the in-house service. Just it's being able to respond in the moment to that need. But it's not an unusual problem, and it's something that the teams work with every day. Okay, thanks very much. So I think out of that, just a number of comments, and I suppose maybe asks that Louise, yourself, and Rhiannon and the team can consider going forward on this area. So clearly there's potentially a very good news story here. So I think we need to consider, ask you to consider how and when we might try to present that good news story to our stakeholders and the general public. When is going to be the right time to do some
publicity work around what we're doing here and the results that are coming forward. I think though, so there was my kind of feeling is that there was maybe 3 areas there that we perhaps need to get some more assurance on as we go forward with these projects. And so first of all, I think, you know, let's commend the teams that have been working on this and coming up with the tests of change, and ask for our thanks to be passed on to them and for the work that they're doing, because I think it's great to see this going on, and especially for us to be, you know, using quality improvement techniques and thinking about evaluation and, you know, taking a very program management approach to this. So, you know, pass on our thanks, and you know, we're lots of good work going on here. But I think maybe, so for me, I heard questions and queries and, you know, Rhiannon has acknowledged that in some areas we don't have the data that we need and that we need to do more work. So I think in terms of ensuring that patient and carer experience of the services are embedded throughout, from consultation on change right through to the outcomes and the evidence that we collect about outcomes, was a key point here. And so I think it would be good to get a commitment for that to be part of our work going forward. And to, you know, I think Rhiannon's already indicated that she wants to see the teams doing more of that. So I think it'd be good to hear an update at some point on that and your plans for community engagement around issues such as the RNI and what its future might be. I think the other area is obviously the financial issues and our ability to achieve, you know, a parity of opportunity, not necessarily the same service across all our areas, but certainly, you know, an equal opportunity to have enhanced services, whatever format is right for the different geographical areas, and how we're, you know, moving forward with a business case that will allow us to offer that to our population. So that sounded to me like 2 areas where the committee might like to receive updates or further assurance going forward. And I would just wondered, Louise and Rhiannon, what you think of that ask, and, you know, if you're happy to come back to us in the future with further information about those 2 aspects of the programme.
Yeah, absolutely.
Okay. Okay, thank you, Wendy. I'm sure Rhiannon would be happy to have a chat with you outside the meeting about the issues around carer involvement. Okay, so thanks very much then, Rhiannon. And do you want to just briefly move on to the other aspects of your paper?
Yeah, certainly. So I'm bringing just an update really on the third sector work of the Third Sector Funding Project Board, because you were very well appraised, I think, as a committee on the work that we undertook pre-COVID, which resulted in some the retendering processes around our and review of our contracts with the third sector. So you just as a recap, we had a number of programs going on, which included a tendering or bidding process for smaller amounts of money, which were under 50,000, and then a slightly different tendering process around for larger, longer term contracts. The larger ones, the over 50k ones, went ahead as planned and were awarded for a 3-year period, so that period is not yet up. However, the smaller awards for under £50,000 we proved to be a very, very difficult process, both from the experience of the organisation, but also the experience of the third sector organisations. And we awarded the funding for a 1-year period only at the time, and agreed to move forward with the next tendering process in a more collaborative and consultative way with the sector. Now that 1-year period was then extended due to COVID and the guidance that was coming out from Scottish Government to suspend most tendering activity at that time. So that period was extended to March, the end of March next year. So we're now in the period for retendering. We gave a commitment to the sector that we would give them 6 months notice of the outcome. So that period is actually fast advancing, and is September of this year to be able to let those organisations plan for the 6 months into the end of March for the new contracts. So this is an update on where we are with that process. We've gone through quite a rigorous and a consultative process with the sector, with over 80 participants in team sessions, looking for input onto the process and the principles, and identifying the priorities both that we have, but also what the sector have, and what would be helpful for them in going forwards in terms of process and how we do this. So we've come up with an agreement on what that would look like, and have actually now begun the tendering process, which opened on the 7th of June and is due to close at the end of this week. So we in terms of the S-bar that you have, things have moved on slightly, so I'm looking at the very bottom of it in the next step, and we do now have those priorities in the report, which is available for everyone to see, has been distributed back to the sector. We are now setting up panels to assess, both local panels and a central panel to assess the applications, to then make recommendations to the project board to be able to let the sector know what the outcome of that is during September. We've also streamlined the process considerably in response to some of the suggestions made by the third sector, including having a single point of access for contact and for advice. So just to let you know that is where we're up to, and we're obviously hoping this is going to be a much better experience for all involved. Any questions?
Okay, before I open it up, Rhiannon, obviously, I mean, we do have a number of new members on the committee. Could you just remind us of the size of the budget for this round of applications, and also what the gap was last time round between the budget available and the total sum of applications that you were received, to give the committee some idea of the very challenging task that people are likely to have in agreeing how to respond to the applications.
Okay, I don't have the exact figure off the top of my head, but it's between £500,000 and £600,000. And in the last round that we did, we had 4 times the number of applications in terms of requiring the funding that was identified in those applications than we actually had. So it was an incredibly difficult process, and there were lots of considerations made which were about sustainability and impact, rather than or also in terms of whether they met the priorities, because the vast majority also met the priorities and criteria that we set. It was a very, very difficult process.
Okay, would anybody else like to ask a question on this topic? Not seeing any hands up. Is Mari with us today? I'm afraid there are so many people on the call that I can't see. Mari Wiley, are you with us, Mari?
She was having technical issues earlier, so I don't know if she is.
Okay. So can I just ask, Rhiannon, clearly this... Oh, James, you want to come in?
Thank you, Anne. This may be a question for Mary Wiley, but I'll ask it nevertheless. It was great to see that there was a great effort to engage with members of the third sector in order to carry out the work, and despite the difficulties posed by COVID, you were able to do this. But what I'd really like to know is how did the third sector and other people that you were engaging with, how did they feel about the process? Did they feel it met their needs?
I think I can answer that. I think we've had very positive feedback from the third sector, and Mary was actually key to facilitating that relationship with them, and she was involved in all of the Teams meetings. She's put a lot of time and effort into that in terms of helping to build relationships with the sector, between them and between us. In terms of the end of the process, we'll have to, I think the jury's out on that one. We'll see what happens. We absolutely won't be able to fund every application that comes in. I don't think we'll be any less inundated than we were before, but I'm certainly hoping that what we're looking for from the third sector is much clearer for them, and that they feel that they understand where we're coming from. That certainly has been the feedback to date.
So Louise, can I just ask you whether you're satisfied that this process of engagement has led us to priorities which are a good fit with the organisation's remobilisation plan, and also I guess for both of you, this can be a very sensitive area of our activities, and are we in touch with Ruth Fry and the communications team about ensuring that there's appropriate comms around this when we eventually make the awards?
Yeah, I mean, from my point of view, I think it's been a helpful exercise to do it the way we've done it, and certainly the as long as people are interested, which obviously Rhiannon has made pretty clear they will be, I think we've got a much better process and structure for getting the right level of support across the board to meet our objectives and to support the services the statutory services. And Rhiannon, okay. I'm not sure whether you can answer on the comms element of it, probably better than me.
Yes, no, the comms app. We haven't put anything out through comms at the moment. It's all the communication around the application process has gone through the third sector interface. But certainly, when the awards are made, we will be involving comms.
Okay, great. Okay, I don't see any other hands up, so thank you very much for that report, Rhiannon. It all looks like it's going in the right direction, and certainly I think it's a very good development that we've managed to incorporate that engagement with the sector at the start of the process. So I don't know if it's still Jacqueline that's very much at the heart of the doing of all of this, but if it is, just pass on our recognition of a good piece of work, and thanks to the team that are still taking this forward.
Thank you very much.
And to yourself, of course, for leading the project board. And okay, that's so I've managed that with 5-6 minutes to spare before I have to let you go. So
thank you.
I hope that's suitable. So I think what I'm going to do is to give us our short comfort break before we move on, and when we come back, Elaine, I'll be taking the finance paper. So it's almost 25 past. So if we could come back in 10 minutes, please, at 25 to. Thanks.
You're on mute, Anne.
Dear. Right, it's 25 to, so I think we'll make a start again, as we still have quite a lot to get through. I'm taking the the finance paper next. So Elaine, is there anything in particular you want to draw our attention to in your paper?
I'll just give you a quick run through, Anne, and then happy to take any questions. There's a few different bits in the report this time. We've got a summary of the 2020-2021 position for both the partnership and for NHS Highland overall, a summary of the partnership position at month 2, quick run through of the build of the financial plan for 21-2022 that was submitted to Scottish Government. So we've covered a bit of that at board and in the board development session, but it'll be new to some of the attendees at the meeting. And then an overview of the current position for the Adult Social Care Savings Programme, which is being delivered in partnership with Highland Council. So looking back first to last financial year, the overall position for NHS Highland, £700,000 underspend, with partnership reporting an underspend of 2.983 million, 2.255 in health and the balance in social care. Within that, there was approximately £50 million of COVID related costs included. And I think as we move forward into this financial year, there's an expectation that these costs will continue in some shape and form throughout 2021-2022 as sustainability payments to independent sector providers continue and some services continue to be provided differently. So quickly then, 21-2022, early stage of the financial year, not particularly doing any formal reporting yet. That tends to take place at month 3, so the end of Q1, when we'll report to Scottish Government for the first time. So partnerships reporting at the moment, an overspend of 2.133 million, so that's quite a shift from the position that we saw last financial year. But what we are looking at is taking into account, I suppose, a return for some services that weren't getting provided last year, and also looking at the recruitment issues that we saw through quite a bit of the last financial year being resolved, and some of those posts that were vacant for quite a time last year being filled. So still to apply a number of uplifts for independent sector budgets, and those will be progressed as well for month 3 reporting to Scottish Government. Looking at the 21-22 financial plan, so we've submitted a 1-year financial plan to Scottish Government, and that will be revisited at the end of Q2, and that's just really to reflect the uncertainty around the impacts of COVID-19 on delivery and the associated funding allocations, which we have mentioned already. The remobilisation plan that was submitted had a significant financial ask in that, and we're still working through a number of discussions with Scottish Government on funding allocations for specific areas. So I think every week at the moment we seem to get another funding allocation out, so that's definitely a work in progress. So the plan submitted requires £32.9 million of savings to be delivered through our cost improvement programme, and I don't think we should underestimate just how challenging that will be. The savings delivery is split into 3 areas. So we've got the cost improvement plan that's progressed and monitored through our programme management office, the adult social care target, and at the moment we've got an unidentified sum of 4.5 million as well. But through PMO and our financial recovery board, we are looking at generating ideas and bringing other work streams into play to identify where we can make savings and close that gap. During 2020-2021, Scottish Government provided an element of funding in respect of slippage against our cost improvement plan. They were recognising there the impact that COVID-19 had had on our delivery of the programme. We're not expecting similar flexibility in 2021-22. So that obviously means we've got a higher level of risk there than we did last year when we knew the Scottish Government were looking to provide funding. So just a little bit around how the budget's been built. We built the budget on a baseline uplift of 1.5%. It's approximately 10 million additional funding, but we also received an uplift of 16.4 million, and that was to bring NHS Highland within 0.8% of parity across the rest of Scotland. So it's a significant uplift, but one that was expected and had been built into plans. The settlement that we got from Scottish Government covers the Scottish public sector pay policy as it was when the budget announcement was made. So that was on 1%. Significant increase from that to the 4% that is now being offered, and Scottish Government have indicated that additional funding will be provided for that, but we're still waiting on that funding coming through. So we're building our assumptions that the money will be forthcoming, and our financial projections are based on that uplift. Within the allocation, there were a number of areas where Government indicated that additional funding would be made available. So primary care, waiting times, mental health and CAMS, trauma networks and drug deaths. So at the moment we received a primary care allocation. We actually just received that over the last couple of days for the Primary Care Improvement Fund. So there's a £4.6 million allocation there for NHS Highland. We've received an allocation for mental health and CAMS and for drug deaths, but still await detail from Scottish Government on the other two areas. When we've set the budget, we have assumed that we would be getting funding from Scottish Government in respect of the costs associated with COVID. So as per last year, we will submit monthly returns based on any costs in addition that we've incurred. We're also providing details to Scottish Government in quite a bit of detail around the Test and Protect programme and the COVID vaccination programme, and are expecting the funding to come in from them. But at the moment, we don't have the clarity on when that funding will be made available or at what level. And then finally, the Adult Social Care Savings Plan. So we identified 4 work streams, and at the 4th bullet point there, it's transitions and children with complex needs. That should actually be transitions for younger adults for complex needs. And at the moment, there's 30 schemes identified, an unadjusted value of 1.985 million and a risk adjusted of 1.196 million. So a bit of work still required there to identify the balance of the savings there. And the difference between unadjusted and risk adjusted is dependent on the view of how deliverable those savings are. So similar to the FRB structure that we've got in place for the health aspects, there's a similar governance process being set up with regards to the Adult Social Care Savings Programme. And then the regular reports that I bring back, I'll just provide a quick summary of that position as we move forward throughout the financial year. That said, quick run through, but happy to take any questions.
Okay, thank you, Elaine. Just before I open it up for questions, can you just clarify the additional allocations that come in during the year that you met, for example, the primary care, etc. What impact, if any, do they have on the forecast position, or is that all already built into our assumptions, so to speak? Does it improve it or make it worse? Either way.
It very much depends, Anne. Some of them are expected, so they're built into our plans, but others come as more of a bit of a surprise, and I think that was definitely the case towards the end of last financial year. The primary care improvement one is one that we did expect, and there is a primary care improvement plan in place to look at how that money will be spent. So in addition to the 4.6 million that we've just been notified as an allocation, we've actually got a balance of 4 million from last year as well that we received fairly late on in the financial year, and Scottish Government agreed that we return it to them for it to be re-provided. So that's kind of where we are. The ones that are mentioned there, Primary Care Improvement Fund, that's built into the plans, but that is the only one at this moment in time. And as we develop the plans for spend, we'll put the costs into the forecast, but also assume the budgetary position as well.
Okay, so basically these allocations will effectively be cancelled out by activity that we have to then deliver.
Yeah, exactly, yeah.
Okay, I just wanted to clarify that. Okay, so we'll open to questions, and Adam's got his hand up.
Thanks, Anne. Thanks, Elaine. I'm looking at the well, what I assume to be the Adult Social Care Savings Plan, section 4, and the 3rd bullet point says child health services, but how are child health services part of the Adult Social Care Savings Plan?
We're looking at it overall, Adam, as part of the quantum. So the quantum that we've got, there's an element for adult social care and there's the element for children's services. So the adult social care comes to us from the council. The children's services element goes from NHS Highland to Highland Council. It's been looked at in the round to see if there's a potential to generate any savings within that health element of the funding that we provide that could have an impact on the overall position.
Okay, Philip.
Yeah, thanks, Anne. I see, Elaine, that there's a couple of mentions of police and custodial services overspend, both in the overspend for last year and so far this year. There was also a couple of mentions of them being resolved. Can I ask, have we budgeted for this within this year's budget, and what's happening with the resolution to the issue?
The resolution's entirely in our hands and it is around to the funding of it. There's a particular way that we need to deliver that service and statutorily that's what we have to do. It is a budget pressure at the moment, but we're looking to identify the funding. There's business cases being submitted, so it's in that element of an unfunded pressure at the moment, and we're looking to fund that this year through slippage in other areas.
So do we think there's an element of risk there, Elaine, in terms of whether we're able to how confident do you think we are that we're going to be able to fund that this year?
I think there is a risk, Anne, and I think we've got to set that risk against the overall savings target. If we didn't have as high a level of savings target, there would be slippage in other areas. But at the moment, the focus needs to be on the savings and balancing the budget overall. But it definitely is a risk. I can't put a high, low, medium level on that at the moment.
Okay, any other questions for Elaine? So can I just ask another point about one of the assumptions in the report, Elaine, about recruitment at 2.2. I think I assume that what that means is that you're expecting to be able to fill vacancies that we haven't been able to fill in the past. Is that correct? And I just wondered if, and that is one of the issues that is leading to a forecast of overspend in the budget. Is that, have I understood that correctly, first of all?
We are assuming that we'll be able to recruit. So towards the end of the financial year, recruitment was beginning to pick up. And when the forecasts have been done at this early stage, there's an assumption that that will continue. I think overall recruitment is a risk to us. So we're looking at it not just within the partnership, but across the whole of NHS Highland, across a number of different staff groups where we are having issues with recruitment. So yesterday, we were actually looking at what we can do to improve that position. But when we're building the budgets, we are assuming a level of vacancies throughout the year. And if all of a sudden that changes and we manage to recruit in great numbers and retain staff, that there is a potential risk there across the budget as well. I'm not expecting the forecast that we've currently got at the moment for the staffing levels to continue throughout the year, but as we move across the months, and we will have a clearer position of what the recruitment pattern's likely to look at, and probably get a feel for how successful recruitment is on a month-on-month basis as well.
Okay, and can you just you've identified the total savings requirement for the organisation as a whole in the paper. In addition to the adult to the savings that are under the joint project board, what is the other total expectation of the Highland Health and Social Care Partnership budget in terms of contributing to that 32.9 million?
They will contribute to a number of the cross-cutting work streams So there's targets for mental health, and in addition to that, there's a housekeeping target as well. I think the housekeeping target's 1.9 million for Louise's area, and she's looking to spread that across a number of different services within the patch. I can bring more details back to the next meeting just around the overall savings plan, and that will show you which elements are related to the partnership and which are sitting within other areas, if you want to do that.
I think that would be helpful. Yeah. Okay, I'm still not seeing any other questions. So I think then, I suppose, I appreciate that at month 2, there's an awful lot of uncertainty. However, the paper is forecasting a fairly significant overspend. You've identified for us a number of risks, particularly the challenge of the size of the savings target, and the fact that perhaps some of the flexibilities that were available to us last year, may not materialise in relation to savings that we haven't been able to achieve, etc., etc. So I guess I just wondered, Louise and yourself, if you could give us any comment about, how you would rate the size of the challenge and the risk that we face this year, and give us an idea of some of the challenges that the partnership will face in terms of ending with a more balanced position.
Do you want me to start, Elaine?
Yep, thanks, Louise.
No
I realise that's a very broad question at this stage in the year, but I think it would be.
It's quite answerable in lots of ways. I think one of the challenges that I see is that this is not our first year of savings plans. So the easier things to do, if you like, that were achievable with less impact have already been done, I suspect. So the challenge has always been savings year on year can be a real challenge to an organisation and to the managers that have to implement that. And there is always more of an ask for services, not less. So it's how you balance that out and how you look at how you do things more efficiently. And again, many of those things will have been done. So it's finding new ways of saving without impacting on the services that you already provide. There's also the new element that we're working with the Highland Council for that joint work. And whilst we have found quite a good proportion of the required savings, there is still some that is unidentified, and there's a pressure on from the two organisations to get that together and get that working. I think we've also got the uncertainty still of COVID and where that goes, and at what point will COVID money dry up, if you like, and will we be expected to continue with some things as business as usual? So there's a number of elements within there, but equally we have got a very managed, structured approach to looking at all of these things. We've got some very experienced staff that have been doing this over the years that have a good understanding of how to achieve savings with as little impact as possible. So I think there are positives within that, but clearly it is always a challenge within health and social care. Elaine, do you want to add anything to that?
I think you've covered it really well, actually, Louise. The impact of COVID and the uncertainty around what funding we're going to get is an issue. At the same time, we're trying to change how we deliver services, and that often comes with a cost at the start anyway. So I think what Rhiannon was doing her presentation on earlier is just one area where we're looking to change things quite significantly. And whilst that will come, that does come at a cost, we need to look at what costs we can potentially save by stopping doing things as well. So there's a whole lot of things that we need to take into the mix. But as for an overall RAG rating, I suppose as a pessimistic accountant at this stage in the year, I'm towards the kind of brighter end of amber. But hopefully we can get that down as the months progress and we get a bit more clarity on funding that's likely to be available.
I think, sorry, just one more thing to add. There is also an odd pressure in that we're being given new monies from the Scottish Government for things, for example, like CAMS and psychological therapies. So there's a pressure on us to improve those services. But equally, we're going to struggle to recruit the staff consistently because we've got a national picture where every single board in the whole country has been given a new pocket of money to spend on those services, and we haven't suddenly knitted a load of psychologists and a load of mental health nurses. So there will be a pressure for us to spend, and savings in those areas won't be seen as positive by the Scottish Government because they don't want to see a saving, they want to see a spending. So there's an odd dynamic there as well.
Okay, so thanks very much. This is currently ragged as amber in our assurance report. Louise and Elaine, do you feel that's still a suitable rating at this point in the year? Yep. Okay. I just wonder whether it would be interesting. We weren't able to bring forward a staff experience or a user experience session at the start of this committee, but it strikes me it might be interesting in the future, Louise, to have a session like that involving staff who have been involved in some of the more major redesign work streams that are part of the PMO work, so that people can get a better understanding of the considerable work that's going into that and the different processes that we're using, including the sort of how we quality impact that work. So maybe something to think about for a future committee.
Yeah.
Okay, so thank you very much then, Elaine. We note the points that you've drawn our attention to, and we've given that a good consideration, I think. So thank you. So I'll move on then to the item on social care fees. Simon, who's speaking to this? Is it yourself?
Yeah, it's me to cover this one, if that's okay, Chair. I'll just so I'm working on the basis that members will have read this, and so if I can just quickly go through a few points for you. This is the report that's on pages 21 to 30. It's a follow-up report from the previous report that we provided on the 28th of April. It's two parts to it. One is about 2021-22 fees. And there's also a briefing on the commissioning briefing instruction remit that we've got. The 21-22 fees, usually it's a process that is impacted on due to Scottish Government involvement. So what we do is we have to work out a way to apply a uniform uplift which relates to the National Care Home contract that we are signed up to and that we engage with. Just so members are clear, the reason that we stick with the National Care Home contract is a strategic decision, is that it works for us, whereas in some other areas, such as, for example, West Central Scotland, it might be possible to drive down the cost of care by stepping outside of the contract. For us, that wouldn't really be applicable, and so it's identified as a fair rate, and we apply it on the basis of that. The impact of the fees is set out in Appendix A. The financial impact is significant. This is a big budget that we're talking about here. So it's £45 million that we spend in the adult social care, what we call the independent sector care budget. And so the impact is £2.5 million, which is included within the financial plan and is a straight pass through that we get through from the Scottish Government. The required uplift has been agreed by the Chief Officer and by the Director of Finance, and is now applied and implemented through the contracts that we have in place. This report is to advise you that the process has been undertaken as we said we would undertake it, and to fully conclude matters, a tender waiver report will go to the NHS board at the next opportunity. So effectively what we're asking you to do in respect of the adult social cares fees 2021-22 is to note that we've undertaken the actions that, that would be required of us. In terms of the second part of the report, the adult social care fees group remit, that's now been updated, and we've provided you with a detailed appendix, Appendix B, which is on page 26, and it reflects a couple of changes. Firstly, approval by the Chief Officer and the Director of Finance. So previously that was the Finance Subcommittee of the Health and Social Care Committee, which no longer exists. And secondly, we've updated the membership to take into account changes in designation that have taken place. We've also highlighted that the remit continues to have the obligation to report annually on fees assurance and to provide an annual contract monitoring report to this committee, which we'll do. And what we're requesting is for the revised role and remit to be agreed. And we also believe it would be helpful for any non-material changes to be made out with the need to report to Health and Social Care so that we don't end up having any significant delays. Just one final point that I would note in the previous minute, and that is that in item 3.6, page 17, paragraph 3, it should be revised to asking providers, not asking clients. It says clients in that. And with that level of detail, you can see that I was well briefed by Gillian Grant, because that's the kind of attention to detail that the contracts team have. So if I could leave it at that, I'm happy to answer any questions that I can for you, Chair.
Okay, thank you, Simon. So I'm going to take this in two parts. First of all, any questions or issues about this year's process, and then the issue about the agreeing the revised terms of reference, for the operational group. So first of all, in terms of the first part of the paper and what has been implemented for this year, do you have any questions? I have a few myself, but Wendy?
Yeah, just one question really, Simon. I hope you don't mind answering my question. I wanted to know that in last year or the year before, particularly pre-COVID and during COVID, my understanding is that there's been an underspend on the budgets that you have had, and if there has been an underspend, is that reinvested into, or is that used as slippage, or is that used to plug any other gaps in service?
I'm not sure which budgets you're referring to, Wendy.
Sorry, you mentioned that there's been an increase in the budget that you have. There's going to be an increase in the budgets in previous budgets that you have had. Does that make sense?
Yeah. Well, apologies. I was not being. Yeah. I sorry. Didn't understand where you're going.
Well.
No. The settlement that we receive with the council is set is linked. Sorry, the settlement that we receive from the government that goes through the council is tied to the establishment of the National Care Home contract rate. So if the rate goes up, the National Care Home contract is an agreement that sits between the Scottish Government, COSLA, and strictly speaking Scottish Care, although CCPS are also involved in it. So once that rate is set, then we receive monies that then allow us to pay that rate. And because we pay the contract rate, then it's a kind of zero balance. We don't save any money out of it, and we don't gain any money out of it. We just pay across what the new rate is. My apologies, I wasn't following you.
Is that what you meant, Wendy?
It is. I think it was my responsibility that I didn't explain myself properly. So I'll be more aware.
We got there in the end. Okay. Does anybody else have any questions? So Simon, could you explain why it's considered that some items on the fee list here should receive a standstill budget as opposed to an increase?
As a discussion takes place within the fees group as to areas where we think we need to increase in line with, for example, national settlements, as I've described, and areas where we can keep it stationary at the time, and that's what we tend to apply to it. So if there is not a pressing requirement for us to increase, then we haven't increased.
So what was the judgment that there wasn't any need to increase fees on the third sector services? How did you come to that judgment?
On the basis of two things, and remember, it's not me personally that came to the judgment necessarily, but on the basis of
it's
two things.
It's a collective view.
Yes, yeah, absolutely. But the position is simply that there is there's a given amount of money available, and that amount of money had not been increased. Therefore, in terms of the third sector provision, it was maintained at the same level. That's different from the National Care Home contract.
Okay, so we could, of course, have made a decision to, despite that, increase those fees by making savings elsewhere or by not funding something else, presumably.
Yes, I suppose we could, and if we were to look at the point that Elaine has made earlier on, at the moment we've got a target of £3 million worth of savings to find. We've actually, I would argue, although not everyone would agree with me, been very successful in trying to identify a way to achieve the bulk of those savings. And in fact, it's only within the adult social care and the adult area that we've actually managed to find that. So we're up to, if you like, a notional £2 million. I'm still, in terms of looking at where we go next, £1 million short of the total that we need to find. And so that's going to require us to find savings. So were we to add additional monies into this, we'd have to find additional savings elsewhere as well. Okay,
so I'll come back to why I see the importance of. I mean, I don't know whether that judgment, would have been one that we as a committee would have agreed on, but I'm asking the question to illustrate a point when we come back to the terms of reference of the group. So but that's helpful in terms of your explanation of how that decision was arrived at. I wondered also, maybe this is more one for Elaine, but what assumptions were built in to the budget about these fees, and have any adjustments been made in terms of the rates that have now been set? So just, I guess, is the implications of the final decisions that you've made, were they already built into the budget, or if different assumptions had been made, have they already been corrected in the forecasts that we saw earlier? Elaine, do you want to come in on that?
Yeah, it's a mix of both, Anne. So at the start, when we start the planning, we build in what we're expecting the national care home rate to be, and that's generally funded through our allocation. So if that moves, we're expecting additional funding to come in, so we build that in. But any increases that are out with that structured approach from government, we will build them into the plan going forward. And if I could also just pick up on what Simon was saying about the £3.3 million savings target, I think we need to set that into context as well about the overall funding gap for adult social care, which when we've done the budgeting this year and the actual financial planning, we're actually looking at an £11.3 million funding gap there. We've got a £3.3 million saving target, £4 million that Scottish Government have agreed to fund, with £2 million coming from both NHS Highland and Highland Council as well. And whilst that covers the problem for this year, it's a significant issue going forward where we don't have any commitment to that almost £8 million of funding that has been put forward this year for next financial year as well.
Okay, thank you. Does anybody else have any questions on the first part of the paper? No? Okay, so let's move on then to the terms. So we're noting the information provided there about what's been implemented for this year, and we're being asked to agree the revised terms of reference for the group that are putting together the proposals on fees. Sorry, actually, I just forgot. Simon, what's the position about charging at the moment? Is that an issue that's still got to be addressed this year, or is due to the pandemic that not something that we'll be considering in year?
Happy to bring back a report on that, Chair. We've had to make a number of alternative arrangements in respect to charging during the pandemic, or we've chosen to do that anyway. So we've removed some charging. Could I bring that back as a subsequent
yeah, sure.
report?
Well,
okay.
I think
Just because it covers a range of areas.
Okay, well, I think, well, certainly I don't feel well informed about what, changes have been made as a result of the pandemic and what might be the financial implications of that going forward. So at some point it would be good to understand where, what the position is with that. So in terms of the terms of reference, Simon, or Louise, I'm not somebody, I wanted to ask basically, clearly the Finance and Resources Subcommittee of this committee doesn't exist, but I wondered why it was thought appropriate to effectively not have any governance as part of the decision making here, in that these terms of reference propose that these matters come to the committee just for assurance rather than for decision, as was the previous situation. So I just wanted to ask why that was thought to be appropriate from my point of view, and that was the reason why I was asking those questions of Simon. These issues raise quite a lot of potential considerations that, to my mind, require some governance oversight. So perhaps you could explain the thinking on that side of things.
Which one? Who do you want? Do you want Louise?
I don't. Well, whoever feels, Louise, yourself, or Elaine, whoever you feel is most appropriate to respond, Simon.
I suppose from my point of view, I'm not used to the old system as opposed to the new, so apologies. I'd probably have to defer to Simon on this one.
I don't think it's an intentional.
You're going to take a pass?
No. I don't believe it's I don't think it's intentional to try and remove governance. I think it was an attempt to try and reset the terms of reference to reflect the fact that the subcommittee no longer existed. And I suppose for me, there's two things have happened. One is that the subcommittee was ceased to exist, so there was there's an attempt to try and maintain the structure of a fees group. Remember, we set the fees group up at a time when it's been slightly iterative because there wasn't one, if you get what I mean, and there was a fair degree of variation around how fees were being set. So that was one of the reasons we set it up, and its kind of governance framework had disappeared. I think the second bit then was the lack of clarity in terms of working out how that was going to fit with the approach that's being taken by this committee in terms of being very precise about what sort of assurance it's seeking or what sort of decisions it's looking to make. So as far as I would be concerned, not speaking for the group, because the group is at the moment a group of officers who are meeting together to make decisions, I'd be advised by the committee. And if you believe that it requires a stronger governance input, so rather than assurance that we're undertaking a number of actions, that you wanted to be involved in the taking of those actions, I'd be advised by yourselves.
Well, does anybody else want to comment on this issue before I tell Simon what I think? Any other of the committee members want to come in on this? So what I would like to ask is that you take this issue away and have a think about it, and bring bring this matter back to the committee. So clearly, Simon, we are not, the committee is not going to be getting involved in terms of the instruction or the, you know, the detail of any of this. But for me, some of these issues raise matters of, well, there are choices to be made in terms of, as Elaine rightly pointed out, we have a substantial gap, so they're very difficult choices. But for example, you know, and they're also choices that would, to my mind, garner potentially quite a lot of attention, public attention, raise, you know, potentially political issues. Should we be moving at any time out of, you know, the fairly standard position of following national contracts or whatever? So I think there's a question here about whether there is a need for some sort of, you know, governance input to the proposals for, you know, what the overall fee structure should be. That was previously there through the subcommittee, and it's obviously gone. It may not be this committee, it may be the Finance, Performance and Resources Committee. I don't know, but I would like to ask that this be taken away and have a discussion with Dave or, you know, whoever else needs to be involved, and come back and, you know, again to the committee in terms of having reconsidered it, whether you want to stick with this position or whether you're happy to find some sort of input from the governance structure, rather than just an assurance input. Louise?
Yeah, I think you've sort of said what I was going to say in terms of we'll go away and have a look at this and come up with what's going to fit the requirements and come back to you if that's okay.
Yep, that's great. Mike, what did you want to come in?
Yeah, I concur with points you've made, and those points had actually slipped by me. I hadn't realised. I just wondered that when the committee was made defunct, what processes we put in place, or whether it just went. I mean, it was a while ago, and I can't remember. But what happened? Did it just disappear? And I think you're quite correct. And this figures in reference to this morning's meeting, is that we have a responsibility of this. And as you said, it could come back. And if it does come back, then we need to be prepared to deal with it when it comes back.
So, well, to answer your question about how the subcommittee was removed from the structures, Michael, what happened was that for some time the subcommittee wasn't operating. Partly that was, well, primarily that was because there had been the experience essentially was that matters discussed at the subcommittee inevitably either ended up being discussed at the committee or in the finance committee of the board. So it was felt that, you know, because the issues that the committee tended to be discussing and deciding on were so significant, that you know, the budgetary implications were so significant for the whole organisation because of the size of the spend of the partnership, that these things inevitably also were discussed at committee or in the finance committee. So it was felt that, you know, and it was a significant pressure on the staff in terms of preparing for and attending that subcommittee. So there was a query raised as to whether or not it was adding value to the governance processes. So it had been in agreement that it would not, that we didn't operate it for a period of time as a test of change, I guess you could say. We then had the board agreed to have a review of its governance committees last year, and as part of that review, the revised terms of reference were devised for the Health and Social Care Committee, which removed the subcommittees from the structure, and that was obviously approved by this committee some time ago. So that was the process by which the subcommittee disappeared. Okay, well, I think that's great. Let's have another look at it and bring it back to the next committee once we've had a chat about that with those and such as those that need to be involved. Okay, thank you very much, Simon. I think, Louise, you're up. Chief Officer's report.
I am indeed. Yep, okay. So as ever, I'm not going to run through the entire report because you might all nod off if I stand and read for some while. So I'm going to just pick up some highlights and happy to take questions. I think just to mention there that I wanted to put it at the very beginning of this around the Feely report, because clearly that is going to be very much our future. And we have done some early initial review work within the board as to what that could mean for us, but only on the aspects in relation to probably some of the less political and contentious areas at the moment, because we do know that there will be potential for structural changes. And as we're not really clear what that looks like, we haven't gone into much more detail at the present time. Clinical and care governance is mentioned there. We are working with the Highland Council as to what that looks like moving forward. We have now got a joint officers group set up and established, and that group is going to form part of that, how we jointly work together and how we establish that governance structure. I think we probably need to set some timescales on how we do that and get that moving in the next few weeks, so that after the school holidays, because that's always a bad time, we've got much clearer understanding of what our structure is going to look like from a governance perspective. There's some detail there around changes to adult care packages during COVID. This came from some questions that were asked subsequent to the last committee, and there are some details there. They're not as much detailed as we would like, because the reality is at the present time our data systems aren't as good as they should be. That is something that we know we've got to work on across the board in health and social care in terms of how we record and report things. We are in some areas still quite heavily reliant on paper, which isn't always helpful, and particularly for audit practices, etc. So we have put the detail we can there, but I appreciate it's probably not as comprehensive as we'd like to be able to report on at this point in time. It does give some assurances though in terms of the communication engagement that we had with individuals and carers during that period of time. Okay, and if we look down in terms of update from the report, there's a number of details there around various updates, and one aspect that I did want to cover in particular, sorry I'm scrolling slowly, is the care home support and engagement. I put quite a fair bit of detail around this in terms of the work we've been doing to support care homes over the last 18 months, and clearly much of that is still continuing. And I think one of the positives from this will be that there will be aspects of this that post-COVID, if we ever have a completely post-COVID, there are certainly aspects of this that will very much feel business as usual. So we have a care home oversight group, for example, that meets fortnightly and looks at where we are with all of our care homes. I anticipate that sort of thing will continue because it's now seen as the norm and quite good practice. So there are aspects of that may stand down over time, but certainly a lot of the things we're doing to bring care homes together and for us to have a better way of supporting them, both practically and from an oversight point of view, will continue. I think that's probably shared fairly well in some of the learning that we've highlighted there. And equally related to the care homes, there was a government ask at the beginning of the year for us to do quality assurance visits across all care homes, which was quite a big ask when you think that this wasn't just about visiting the individual care homes, it was reviewing the packages of care for all of the individuals in care homes, which is quite a number of people, obviously. So you will see there a breakdown of where we are with that, and we've made really good progress. Both with those quality assurance visits, but all with the individual reviews, because you can see we had 1,700 to do, and certainly as of the time of reporting, we'd actually achieved, by now we will have achieved half of that, which I think is pretty good going in the timescales that we've had to do it in order to do it properly. Okay, and there's some details there in terms of supply relief and what that's meant in terms of supporting services for sustainability. And again, that's very much that COVID specific ask in terms of how we support people. The big challenge is going to be, again, as we mentioned earlier, when the COVID money isn't there any longer, how services will come out at the other end of this. There's some detail also in the report about daycare services for older people and also for learning disability services. We have now remobilised a good proportion of our services, and we have supported private providers to remobilise some of their day services as well. There are 1 or 2 services that were there prior to COVID that may not be remobilising at all. Not our own services, but certainly services from other providers. However, I don't think we've got the final decision on those. It's a small number, but it may have an impact. So we've got to be very mindful of that and seeing what else we can do to support people if those services choose not to come back online. And again, there's some detail there about respite services, because we haven't been able to recommence respite services, unfortunately. And again, that is a national picture, but we have got the plans in place so that we can do that where we are able to. Okay, we've put some detail about the self-directed support strategy in that we're working on the plan. We were hoping to get nearer to having the draft strategy completed, but we have still got a fair bit of work to do on that. So we're anticipating a date of around November for getting the strategy completed. If we can bring that forward, which I'd like to do, we will try and do that over the summer. And certainly there's an update there again on the partnership agreement and integration scheme, because clearly, as people are aware, the integration scheme has been through many hoops and processes along the way. The consultation period closed. There wasn't a huge amount of change required, and therefore it has been signed off by both the council and our own board within NHS Highland, and the ask now is for the Scottish Government to approve it, and we are just waiting for finalisation of that so that it can be formally published. There's some detail there about the Mental Welfare Commission report that some of you may have seen that was published. This related to decisions about people that were moved out of hospital during COVID who lacked capacity, and the Mental Welfare Commission did a report looking at a window where people were moved from hospital to care homes and whether that was done in the correct way. Funnily enough, we had a meeting only this morning with the Mental Welfare Commission and went through their recommendations from the report to look exactly at what the future holds around this. And what they did actually say is that although this report was initially looking at that COVID specific period, what they've identified nationally, not for here specifically, but nationally, is that there are learning needs for all of us that would have been there pre-COVID if they'd done this work. It wasn't just about COVID. So some of the learning about training for adults within capacity, for example, are things that we've picked up because of COVID, but actually they're really good learning points that we should have been taking on anyway. So as a board, we're quite happy to look at that and work with other boards and other local authorities, because things like training, there's a feeling that needs to be a national training offer rather than just localised, so that we get that consistency. So as I say, there's going to be a fair bit of learning from the report. Okay, there's a section there in terms of children and young people, and it gives an update on the progress and steps around improving performance and oversight of the children's services, and also that the board is currently refreshing the children's and young people's work stream, and we're anticipating that as we move forward with this, we'll start reporting much more substantially on children's services within the Health and Social Care Committee. Okay, I think I'm getting there. The last part is around the service redesigns that we've got going on at the moment. As people know, Skye is close to being completed in terms of the new hospital, and now we're still working on the options appraisal around the North Skye services. We also had what we thought was the final Sir Lewis Ritchie steering group. However, there's been a bit of a regroup on that one, and we're going to have one final one to relaunch, doing a new group which is around quality improvement, but that's going to be for the whole of Skye, not just about North Skye. So there's some developments going on over there. And in Caithness, the redesign work, the initial agreement, which is the first stage of the submission to the Scottish Government. It's a three-stage process, so the first stage of that is well underway. Unfortunately, it was waylaid by COVID because this was something that predated me being in post, but we've restarted now the Caithness programme board, and we've restarted the work on that. The work on the initial agreement never stopped, it just slowed. So we're hoping to get that fairly soon, that could be submitted to the Scottish Government around funding for the redesign. And likewise, Loch Arbour is at a very similar stage in that we've got a governance structure in place. The initial agreement we're anticipating will be completed by October for submission in November, and again that will be really asking for funding. Specifically at this part of it is for the new hospital. And finally, just some details around route to the meeting, and that's it.
Okay, thanks very much, Louise. So I've got a number of people wanting to ask questions. So I'll do a couple and then I'll come back to you, and then I'll do another couple. So I'm going to go first to Deirdre and then to Wendy, and then after you've responded, I'll come to Mike and Adam. So Deirdre, do you want to kick off?
Thank you very much, Chair, and thank you, Louise, for your very comprehensive report. I have a couple of questions. One on children's reporting. You did suggest that we could be looking for a report quite soon. Do you think that might be in time for the next committee? That's my first one. My second question's in respect of the Mental Welfare Commission. Are you able to tell us when we can expect an action plan for improvements to come to a future committee? And also, are you in a position to elaborate on why the information wasn't provided, and are there any outstanding consequences to that? Thank you.
Okay, Wendy.
Just a little bit of clarity. I have a couple of questions, but some clarity around in the last meeting, I think it was Danelle actually that I asked some questions, and I was wondering, in the report that you submitted, was that in an attempt to answer the questions that I've asked? I'm just not entirely sure that was your rationale for the response. Is that in the report, the questions that I asked, your answers? The second thing is that thinking about carer representation and care feedback, I was wondering whether you would consider some other sources of evidence of lived experience. And the final one was when I was thinking about the remobilisation of day care centre sessional work for in daycare centres, it was evidenced in there that that you were very clear that it promoted person-centred approach. I suppose one concern that I have is that if you were only giving people an option of having an occasional session, how that equates to that being a personal-centred approach. Thank you.
Okay, Louise, do you want to?
Yeah, okay. So the first aspect was about the children's report. I think Tracy's in the room, and I know Tracy's been working with Sally and colleagues from the local authority. I just don't want to put you on the spot too much, Tracy, but do you think in terms of timescales for reporting, the next committee is achievable, or have we still got more work to do? I'm sure Tracy was there a minute ago. If she's not there anymore, what I can do is go away and check and get back to you if that's okay. Because oh, Tracy is definitely showing up online, but she's vanished. Okay, so I'll get an update on that one because I don't want to commit the team to something until I'm sure that they're ready for it. So if that's all right, I'll come back to you on that one. Is that okay? Okay, so on the Mental Welfare Commission action plan, we have to submit something to the Mental Welfare. Oh, Tracy's struggling to get off mute, she said. Okay. In terms of the Mental Welfare Commission response, we have to do a response to them with our actions by August. So we have a timescale to them. So in the meantime, we'll be doing our own internal works on what that looks like. And I think they've probably given us a healthy-ish timescale, A, because of holidays, but also because there's a desire to look at this from a national perspective and look at what the training opportunities, for example, would be nationally. So what we'll make sure we do is that whatever we're submitting to the Mental Welfare Commission, we're sharing with this group as well. And in terms of the information not being provided, the initial, or certainly the view internally from our legal department, there was some concerns around data protection because the information that we were asked to share was for all discharges from hospital to care homes, regardless of whether they had capacity or not. So we had some internal anxieties between ourselves and the council as to the appropriateness or otherwise of sharing everybody's data as opposed to those people we deemed as not having capacity. Ultimately, after some liaison with the legal office, the National Legal Office and the Mental Welfare Commission, we made a decision that we would support giving the information. However, by the time we'd gone through that process, we were too late for it to be part of the report. So that's why in the report it suggests that they hadn't received the information on time, because they hadn't, but we had ultimately said we'd give it.
Thank you.
And in terms of when your questions, Wendy, that was an attempt to respond to them, but if it doesn't read sufficiently enough, then I'm more than happy if you want to come back in anything that you don't feel is in that section that we put in the report. Is that okay?
I wonder whether the chair and everybody would be happy, instead of wanting to, I don't want to take up too much time, whether everybody would be happy with me to have a separate conversation with Louise or someone else. Would you be happy with that, Chair?
Well, I think the important, I think that what's important is that the committee as a whole is aware as to whether or not the team have provided sufficient assurance around the issues that you've raised, Wendy. So I think that if you still have concerns, following on from the information that you've received in the report, then perhaps what we need to do, Louise, is think, I mean, we already have in the work plan, some items that would cover some of the, the services that Wendy has asked questions about. So, perhaps we need to look at bringing a specific report on, on some aspects of our remobilisation. So perhaps the thing to do is for, I'm more than happy for you to have a conversation with Louise, Wendy, and then Louise and I can agree how we're going to bring that back to the committee. Okay, so because it may be that some of the other reports that we want to bring forward, later in the year, could be advanced or whatever to try and address any lingering concerns that you might have. So why don't you have a conversation with Louise to start with, and we'll see what we need to bring back to the committee and how.
Fantastic. That's okay with me.
Is that okay? Yeah, is that okay with you?
Thank you. Thank you.
And then just on the other points, the one about care representative feedback and lived experience, totally support that, Wendy. My background is working in mental health, and I'm used to lots of service user and carer involvement as part of that. I suspect that some of that has been more challenging during COVID because it has been a bit all hands to the pump, but it is certainly an area I'm really keen that we really establish and develop more of, because ultimately, there's no point providing a service if it's not the right service. We need to get that feedback. So more than happy to perhaps have that conversation offline as part of the other dialogue we're going to have. And in terms of the day centres, I think the challenges at the moment that the day centres themselves are still not able to run as they would have done previously. Because there are limitations around how many people can be in them, mixing, etc. So I think particularly some of them are sessional because there's limits on what we can offer people right now. But I wouldn't anticipate that day centre support would be one thing. It should be part of a wider package of support that's agreed with the individuals, with the carers, etc. So I am. Whilst I understand what you're saying in terms of that isn't necessarily person-centred, I would hope that people are experiencing much more of a broader picture than just that limited day centre support that we can give at the moment. But again, that might be something that we pick up in that lived experience work.
Okay, so can I turn now to Michael and then Adam?
I just wanted, Charles, going to bring this point up in matters arising. I wasn't quite sure whether we'd bypassed that or whether we were coming back to it.
No, well, I'm going to finish up with the assurance report and any matters arising from it, Michael.
On page 18 of the minutes, I requested a report on the North Coast redesign for the next meeting. And on page 52, hang on, my thing's slipping. Right, page 52, I've noticed that the North Coast Care Facility Programme has now morphed in from North Coast Redesign. Now, when the North Coast Redesign started 6 years ago, it was all about the health and social care of the communities from Melvick all the way down to Kinlochbervie. And what I'm concerned here is now it looks like North Coast Redesign has now morphed into the care facility programme. I remember at the beginning of the meetings, this was only supposed to be part of the discussion about health and social care on the North Coast. I'm also concerned that there isn't an update. It wasn't mentioned. And I understand, and Deirdre might be able to help with this, is that the Highland Council had full council on 24th of June. This matter was discussed there, and I wondered what the outcome was. I know there's a meeting of the, I don't know what it is now, the North Coast redesign on the 15th of July, and we're having more meetings, and it's more focused, and I appreciate that. But I would like to know whether the North Coast redesign has now just become an adjunct of Caithness redesign.
Okay, and then Adam. Sorry, Mike. Was that all? Is that all your questions you wanted to raise? Yep. Okay, so Adam, and then I'll come back to you, Louise.
Thanks, Anne. Thanks, Louise. My question is about the Sky redesign, and I'm a bit anxious about the workforce planning and the amount of additional staff that are going to be required for the new hospital in the light of the Lewis Ritchie follow-up. And I suppose I'm wondering if you can give us an assurance, Louise, about what's happening with that, and whether we think we are going to recruit enough staff in the light of all kinds of things like difficulty with housing and so on.
Yeah, absolutely. So apologies in terms of the use of language on the North Coast. That should really say Caithness and North Coast redesign. They have been put into a single board, but they are two distinct projects. So when we had the first programme board meeting, Caithness redesign and North Coast were covered separately within that, and they will continue to be. It's just because a lot of the same people are involved in the two conversations, it made sense to, I won't use to lump together, but put the two things together. And absolutely, we've only had one programme board up to now, so it was really just an update and refresh on where things were with North Coast and with Caithness. So I anticipate moving forward that we'll look at the broader picture, not just those specific points. So it's more about the language in the report around the care facilities, to be fair, and we will broaden it out as those meetings progress. So apologies for the language on that, but we'll make sure that everything's covered within it. And I think it's probably worth saying that's similar with Loch Harbour, for example. Although the focus at the moment is a new hospital, we've been clear with the community there that that won't just be the focus of the meeting as we move forward. The stakeholder group will be looking at all aspects of care within Loch Harbour. Okay, are you all right? Do you want me to carry on to the next point, which is Sky? Yep. In terms of Sky, we have got a challenge in that the original business case for the new hospital was predicated on changes that aren't currently going ahead in North Skye around Portree. So what we have done is Tracy has done a draft business case to look at additional staffing for the new hospital, so that whatever happens with the options appraisal that's still ongoing in the north, we will have enough staff to achieve what we need to in the new hospital. That has only recently been submitted, and myself and Dave Gardner looking at that to see what the cost impacts are. It will have a cost impact because the reality is we are running more services than we anticipated running when this was first designed. But we've got a new hospital and we've got to staff it. So we're working on how we manage that through, Adam, and I'm happy to bring that back and update.
Thank you.
Can we perhaps agree then, Louise, that at the next committee meeting, your Chief Officer report will include a specific report on North Coast?
Mm-hmm.
Is that okay? And I saw Fiona had her hand up. I don't know if you were wanting to come in, Fiona, on the point of what was decided by the council. Was
yes,
that it, or was it something else?
I was just putting a wee bit in the chat just to say that there's actually a paper going to September Council on North Coast. So there will be that paper will be getting pulled together in August. So I'll have much more to report at that point.
And could I just bring Tracy back in on the children's, because she's managed to get her system working again?
You can. Is there? I take
I'll
it.
be quick, Anne.
Well, that's okay, Tracy. I'll come to you. I just want to finish this point on the North Coast first. So if that paper's going in September, Fiona, I take it we still have a steering group, Louise, or something sitting below the programme board. I'm just wondering, I guess, whether there is a steering group meeting planned before September so that people locally can be kept up to date with, with what the situation is as regards any proposals going to the council, etc. Would that be appropriate, or?
I can catch up with Fiona and we can make sure that we're linked in on that.
Okay, so, well, I think it would be, I mean, I don't know if there's been a steering group meeting recently, Michael, has there?
Yeah, there was one in May, and because it's all been reprogrammed, we've got a meeting on the 15th of July. But what I was concerned about is that over the years, a lot of this has depended on meetings of NHS Highland or meetings of the Highland Council, getting the two to interact. And the whole idea, and what I was led to believe, that this meeting on the 24th would agree and basically sign off. So at this meeting, the information could be, say, the Highland Council. And the impression I get now is, and there's obviously nothing I can do about it, this has now been put back to September, which then puts the programme back, unless someone can tell me the programme hasn't been put back. Well,
if there's a meeting scheduled for July, then Louise, perhaps we could ensure that, you know, some sort of assurance is provided that the timing of that report, you know, to the council isn't holding things up, or that things are still, you know, progressing in tandem. Would that be okay? Okay. Deirdre, do you want to come in on this before I go back to Tracy?
Yeah, just to add briefly, to offer Michael a degree of assurance and confidence. You know, as you know, Councillor Linda Munro is absolutely steeped in this. It remains a very local project. And part of the delay has been in the negotiations with Wildland, so it's been quite practical.
Okay.
So it's just to offer that assurance, yeah.
Okay, Tracy.
Yeah, just very quickly to come in on the children's services side of things. So the question was whether the report would be ready for the next meeting of this committee. And I'm having monthly meetings with Sally Amor, who's leading on this within NHS Highland, and she has assured me in my last meeting, which was earlier this week, that there will be a couple of reports coming to the next committee. So there'll start to be a regular assurance report for us on children's services that we'll be able to see. And she is also intending to bring a report around the partnership and performance and improvement around the partnership.
Okay, thank you, Tracy. So any further questions from members of the committee? Can I just a couple of well, one a question and one just a comment I'd like to make. So Louise, there's obviously been a huge amount of work had to go into this individual reassessment of individuals in care homes that we've been required to undertake by Scottish Government. And, you know, it's great that we've undertaken as many as we have, but I just wondered, it looked to me like we were quite, well, we were perhaps going to be struggling to meet the original deadline that they'd set for us. So I just wondered if that had been extended, or if we are in dialogue with Scottish Government about the progress that we're making, whether they're happy, you know, are there any issues around that or not?
I think the progress has speeded up on the grounds that obviously when you're first doing it, it takes a little while to get into the swing of things. So we are progressing more quickly than we had at the beginning. However, I appreciate what you're saying. I don't know whether Simon or the team are able to give more of an update at this point, but if not, I can check that out and get back to you.
Denellen, do you want to come in?
Yeah, thank you, Chair. Yes, so just by the time you set them up, it takes time, but we are confident that we will deliver with all in Highland reviews. That's 1,700, and we have been able to get some additional resource through some of the monies. I mean, we've obviously spoken earlier about the monies and not been able to recruit through to all the posts, but we have been able to get some recently retired staff, etc., to help support that. So we are confident that the Highland reviews will be, but where we will not deliver within the timescale, which is the end of July, are the out of area reviews. So there had been just some discussion at the Chief Social Work Officers group around sort of some reciprocal arrangements, you know, for each authorities doing the out of area reviews. But that we've got a few reciprocal arrangements with the smaller authorities, but not some of the bigger ones who've got a lot of out of area placements. So there has been some dialogue with our colleagues and the government around that, and we are just at the moment preparing plans as to how we you know, so that we've got a timeline for that and that we're able to present that, but that will definitely be after the end of July.
Okay. Simon, did you want to come in? Thank you,
Yeah,
Danelle.
just a very quick point. Danelle and the team have done an amazing job both managing to attract people to work on this and also to achieve what they have. Like you said, it's over 1,700 reviews we're talking about. It's a mammoth task. I just want members to realise, however, there is a limited number of social workers and there's a limited amount of social work capacity in Highland. So at the same time as we're delivering on this, we're also getting concerns rising about the pace of social work assessments that get undertaken. And unfortunately, every time we take on something like this, something else has to give. And I think we just need to recognise that, combined with all the other pressures we've described of an overheating system, means that we've been instructed this is a priority that we have to take forward. And it would be really helpful for the committee to recognise that that's the case when there are other pressures also being described, such as maintaining flow in hospitals. Thanks.
Okay, well, that's absolutely very true, Simon. And I think, so in terms of just finishing up this item, that sort of neatly introduces the comment I wanted to make, which was that, you know, this item is always about escalating pressures in the system. And I think it's important that we remember the huge positivity in some of our earlier reports and you know, the work going on in enhanced community services, etc. But also I think it really brings home the amount of plates that our team are spinning constantly, and plates being added every day to that. And also I think we've also had emphasised today that we need to remember that although the COVID cases are no longer impacting necessarily on our hospitals in such a significant way, they are still impacting hugely on other parts of the system, whether that's because staff are self-isolating or because we're operating under government guidance, which means that we can't remobilise our social care services in the way that we would wish. So I think I just wanted to you know, make explicit that you know, certainly I, and I hope the rest of the committee appreciate the constraints that the team are operating under, and that there are still very significant COVID-related pressures impacting on the system on a daily basis. So thank you to all of the team for you know, for the excellent work that is going on despite those pressures. So thank you, Louise. I think that we are noting, is there anything that anybody out of that feels needs to be escalated beyond the further activities that we've already agreed around North Coast and the discussions with Wendy? No, okay, so we're happy to note that the assurance you've provided, Louise. And finally, can I just then round off with going back to our assurance report. First of all, matters of accuracy. Did anybody have any matters of accuracy to raise on the minutes? Don't see any hands up. Okay, did anybody have any matters arising that were not otherwise on the agenda? Okay. In relation to the rolling action plan, there's a number of these items, Stephen, that we need to update. For example, item 1, we can remove that, I think, because as we discussed earlier, the subcommittee issues have been addressed and the clinical governance issue is otherwise on the rolling action plan. But I think, Louise, there's also, for example, Arlene's name was against some of the update reports on day services and on the patient experience of the pandemic, and Arlene's undertaking a different role, as I understand it, at the moment. So, you know, I think there's a number of these items that Louise and I need to go over and update, and for the next committee, we'll have a refreshed version of the action plan. And there are a number of items that we've agreed today that need to be added to that, obviously. So are you happy to approve the assurance report and note the action plan? Don't see any dissenters. So that brings us then to the work plan. I think, again, what I'm going to suggest, we had, sorry, I'm just adjusting my papers so that I can bring that up. So I think there's a number of items that we may need to shift around, Louise, in terms of timing. And there's a number of other papers that we haven't received that we expected that we're going to have to accommodate going forward. So again, I think we need to do a bit of work revising this and then come back to the next committee with a proposed revised work plan. Yeah. But I would also be proposing to try and bring to the next committee a draft development session plan, if you like, to sit alongside that. We did get some suggestions from the committee for development items, but is there anything specifically that people would want to suggest for the actual work plan at this point in time? Okay, I don't see any hands up. So if you're content, then Louise and I will try to incorporate the various items that we haven't managed to bring forward, such as community planning and the performance framework that we did expect, and rejig this and bring back a revised version to the next committee if you're content with that. Yep. Everybody happy that we do that? Okay. Right. Is there any other business that has not been on the agenda? I haven't been notified of any, but is there anything else anybody wanted to raise today? Michael?
Yeah, just a quick thing. We've talked a lot about community services. I'm just wondering if we're ever going to maybe discuss